Good evening, everyone, and welcome to this Lumbar Spine Research Society webinar on telemedicine for the spine surgeon. Telemedicine and telehealth has been a technological fascination for several years, and it's only now with the COVID crisis that we've been forced to incorporate it to a much greater degree into our practices. The Lumbar Spine Research Society decided about 10 days ago that this would be an outstanding topic to put on a webinar, a virtual webinar for all of our members and others who are interested in learning about telemedicine. We're very fortunate to have 3 spine surgeons who are experts in telehealth and have been using telehealth in different forms and varieties for the last few years. So we put together this panel, and after their talks, we'll have ample time for discussion and questions from the audience. Hopefully, this will be an informative and practical use of your time for the next hour. Our speakers this evening are Raj Patel, who is in his real life mountaineer and climbed Mount Everest last year. In his spare time, he's a spine surgeon at the University of Michigan, and also focuses and does a lot of work with the state of Michigan on telehealth. Mel Helgeson is chair of orthopedics at the Walter Reed National Military Medical Center and has also been using telehealth for several years, dealing with military personnel all over the country and all over the world. And Jim Harrop is professor at Thomas Jefferson University and also has been using telehealth extensively over the last few years. The webinar is moderated by Paul Anderson from the University of Wisconsin and by myself. The agenda is Raj will talk about how he's been using telemedicine, practical telehealth, various platforms and patient selection. Then Dr. Helgeson will talk about his practical use of telehealth and lessons from the military and regulations that impact our use of telehealth at this time. And then Dr. Harrop will talk about his practical experience with telehealth and reimbursement issues that impact our use of telehealth. The logistics, the telehealth webinar will go till 9 p.m. Eastern time. We've maxed out at 150 participants. The audio will be muted by Katie, who's our administrator, but please mute your audio if for some reason your audio springs to life. There are 2 audience polling questions that we'll start off with, so please look at your dashboard, which may be on the right side of your screen, and there should be a button that says polls, and I'll launch the poll momentarily. There will be a Q&A period after the 3 talks are completed. There's a questions tab on your dashboard, on your control panel. Please enter any questions you have in that questions tab, and I'll see the questions and respond to them, and the various speakers will respond to them as we move along. So here's the first poll coming up for all of you. We just want to get a sense of where our audience is in terms of their use of telehealth. Please respond to the poll on your control panel. You have occasional familiarity with telehealth. You schedule time aside for telephone calls with patients. You have occasional video chats with patients. Or you have billed occasional video encounters or frequent video encounters with patients. Okay. We're almost there. We've gotten about 80% of results in so far. And we'll close the poll at this time and we'll share the results with the audience. Okay, and then we have one, so that's about, I think, I'm surprised that there are a few of us that occasionally are using telehealth and billing for these encounters over the last few months or years. But still, the vast majority of us, I think, are not familiar with how we can use telehealth maximally. And then finally, we'll have this second poll, which I'm going to launch momentarily, which is what you hope to learn most from this webinar. You want to learn about the types of patients and platforms that are most suited to telehealth, pre-visit prepping for a telehealth encounter, how do you navigate the mechanics of your telehealth visit with a patient, regulations and reimbursement. So please go to the polls section on your control panel and respond. Okay, so about 75% have voted, 80% so far. I'll close the poll and we'll share the results. So that, in a nutshell, is what we hope to do with this webinar as well. We want to talk to you about the various types of patients and platforms that may be most suited to telehealth. We'll talk about how you prep for a visit before the visit, navigating the actual visit, regulations, and reimbursement. And with that, let me hand it over to Raj Patel from the University of Michigan, who's going to talk to us about his practical use of telehealth for the last few years, how you can optimize your session with the telehealth encounter with your patient. Raj, it's up to you. So you should be present now.
Great. First of all, thank you everyone for joining us for this webinar. So as Raj said, I'm from the University of Michigan, and I know that there are a varied group of people in the webinar today. I'm sure there's some people watching this who are also in academic centers. There are others who are private practitioners and those that are also employed by hospital systems. And even though we have different workflows and different restrictions in all the different work environments, I can tell you pretty confidently that telehealth is going to play a really important role in all of our lives in the future. So my objectives of this talk are to go over the history of telehealth, to briefly talk about its benefits, to talk about the current applications, and tell you how we optimize our workflow at the University of Michigan, and to talk about areas for future improvement. So, I mean, the first question is, what is telehealth? So telehealth is simply the ability to take care of a patient at a remote location with telephone or video conferencing. It's really not that different than minimally invasive surgery in the sense that MIS surgery essentially accomplishes the same goal as open surgery, just with a different technique. So telehealth is not a new service, but yes?
Raj, I can't, your slide's
yes.
just a blank screen right now. Did you advance the slide or did you have anything?
Oh yeah, I could see it on my computer. And it shows that it's sharing, so.
Can you advance the slide?
I just did, yeah. Hey, let me end show and try it again.
There you go. I can see it now.
Can you see that now?
Thank you. Yep, I can see it. Thank you very much.
All right. Sorry about that. Yeah, so like I was saying, telehealth is not a new service, but it's just a different technique for us to administer the same service. And the same service in this case is to assess and follow up our patients. So the benefits of telehealth are several. The main reason why telehealth came into existence is to take care of patients in remote locations and to give them specialty care in these remote locations. It also is a huge time savings for patients. In Michigan, we have patients driving from the UP, which is roughly 10 hours away, for a visit with us. So it's a considerable time savings. That translates into improved patient satisfaction and also leads to quite a bit of cost savings, both direct and indirect. Jim's going to talk about cost savings, but really briefly, in terms of indirect cost savings, patients don't have to take time off from work. In terms of direct cost savings, you need less resources. You don't need as many people at the front desk. You don't need as many MAs. So your overall direct expenditure is less. The first kind of study on telemedicine and spine surgery was in 1995 out of Finland. So you can imagine the technology in 1995. There weren't iPhones and BlackBerries were just new. And essentially they used telemedicine to help provide specialty care for a rural location. So in this situation, there was a small town in Finland where they had a general practitioner examining a spine patient on the right. And that was teleconferenced into Helsinki. And there was a spine surgeon there watching this. And they found in this study, and they published in subsequent studies, that this was a really effective way of delivering quality care. Patients were satisfied, and there was a big cost savings. Now, fast forward to 2020, everyone, including my daughter, has an iPhone, an iPad, and a computer with excellent video capability, and the internet reaches kind of everywhere in America, right? So now we have the capacity to deliver care to patients wherever they are, at home or at work. But interestingly enough, even though we've had this technology for about 5 or 6 years, not that many people are doing televisits. And pre-COVID, I can tell you, it was really very few people that were doing video visits. And there are a few reasons why. One is clinical appropriateness, meaning providers didn't know which patients were appropriate for video visits. Another was uncertain reimbursement. So not all insurance carriers reimburse these visits. And the biggest one, in my opinion, is there were a lot of potential HIPAA violations, and there weren't that many HIPAA-compliant platforms to do these video visits. So my hospital, like I'm sure a lot of yours, has adopted Epic several years ago as our EMR of choice. And amongst Epic, there is a telemedicine platform that we've been using. So once I realized we had the capability of doing these video visits, I asked myself, which patients would I do this on? For me, the immediate answer were patients who do not require a physical exam or in-office imaging, like x-rays. So the perfect example would be someone that comes into my office and has lumbar verticulopathy and a positive straight leg raise. I think they have a lumbar disc herniation. So I tell them to do physical therapy, and my next visit is a video visit. And I see how they're doing. If they're not doing well, I can order an MRI, and I could review that with them virtually as well. And if that's not working, then I could order an epidural injection virtually as well. And that leads to either surgery or resolution of their symptoms. In any case, we've limited the touch points to just the initial touch point and the final touch point and skipped everything else in the middle, which is a huge cost savings for healthcare dollars, and is also really big time savings for the patient. So I was really excited about doing this, and that demographic constituted about 25% of my patients. When I first started doing it, I had over a 50% no-show rate. So it was a huge waste of my time, and we also didn't capture a lot of patients. And the reason was, in order to do a televisit on Epic, patients needed to be enrolled in the portal, which would give them access to look at their medical records. And they also needed to download an app on their smart device, their iPhone or their iPad. And patients just weren't doing this. So we altered our workflow. So when every single patient checked into clinic, we made sure that they were registered for the portal. And the ones that were flagged for video visits on checkout, we had people assisting them at that very time to download the app onto their phone. The other barriers that we had were insurance coverage. And this is going to continue to be an issue post-COVID, and I'll let Jim talk about this. But there were several insurance carriers that covered these virtual visits, but a lot of them didn't. The hospital recognized that this was going to be an initiative that they wanted to put their weight behind. So essentially, we offered really discounted out-of-pocket rates to patients whose insurance didn't cover it. And it was just a few bucks above what their normal copay was. So it really incentivized them to do video visits. And the last barrier was, even though we set this up for them and we fixed their insurance issues, patients didn't always know how to use the app. So essentially, we printed out these 4-page brochures and we hand them out at every visit and also online. And the thing that we highlight is roughly 1 week in advance, they do a test of their audio and their visual system to make sure it works. So implementing these things has really reduced my no-show rate. Now it's actually way less than for traditional in-office visits. And this is my basic setup. This is where I am right now. So this is my home setup. I have my laptop computer, and I can look at x-rays, MRIs, and CT scans on this. And I also document on that as well. I have my iPhone at home, and I use an iPad at work to communicate with the patient. And I have a pad where I basically write things like which cases I'm going to do and specific details about the case. And at the end of the day, I send that to my scheduler via an email, and it just gets scheduled. So this is what I see on my smartphone. So starting from left to right. Once a patient arrives for their visit, they get put in a waiting room. So this patient, for example, arrived at 10:40, and then when I click on the patient, I have the ability to join a video call, and I see the patient like this slide demonstrates all the way to the right. So I schedule my follow-up patients for 15-minute intervals. And I initially thought that I was going to have a problem in terms of falling behind in my day. But 1 or 2 minutes before the visit is over, if I have a feeling like it's going to go longer, I simply tell the patients that we have to stop in a minute or two because we have another patient waiting. And I always suggest that if they have more questions, they could schedule another video visit. And surprisingly, this has not been met with any resistance. And I think this is because I'm always on time, and patients appreciate that. And also, there's really very little burden for patients to do video visits. They just basically log on from any location and they're there. So this has really worked well for me so far. So about 25% of my patients qualify for this demographic, and I wanted to do more patients with video visits. And I thought, how about if I include post-operative patients in fracture follow-up, right? And my concerns were, how will I be able to assess hardware post-operatively without x-rays that I take in my office? How will I be able to evaluate the wound? And in terms of fracture patients treated non-operatively, how can I assess their fracture position? Well, there's plenty of literature, both in the cervical and lumbar spine, talking about the utility of post-operative radiographs in patients. And all the studies essentially show that if patients are doing well and don't have any clinical complaints, you really don't need to do post-operative x-rays. And that's kind of what we've implemented. And the same could be extended to fractures. There are certain fractures, like if you had a Jefferson burst or a hangman's, where you'd want to get a flexion extension at some point. But the majority of fractures that we see are compression and burst fractures. So if people are doing reasonably well, there's no need for x-rays. And all of us have kind of been forced into this in this COVID era, and most patients are doing just fine. My initial concern about ability to evaluate a wound has really dissipated pretty quickly. I think the resolution is really good on these cameras, and we've had no problem so far evaluating wounds post-operatively. So the only group of patients that I wasn't seeing virtually were new patients, right? And of course, you can't see new patients because you can't do a physical exam. But that had me thinking, how important is a traditional physical exam for the diagnosis and the longitudinal follow-up for spine patients? And quite honestly, how often do I actually do a physical exam? I have my residents do it, but how often do I follow up on it? And when you think about the key component of most of our physical exams, it's our manual muscle strength testing. And the MRC committee developed this 0 to 5 grading system that we all uniformly use in 1940. So that's 80 years ago, right? In the last 80 years, so much has changed in terms of technology, but we still use the same grading system. And there are a lot of problems with this grading system. The 0 to 5 scale would have you believe that it's this linear, purely objective way to judge muscle strength. And that's what we want, right? Something very objective, so you can establish a diagnosis and so you can follow patients longitudinally. And arguably 0, 1, 2, and 3 are objective. But once you get from 3+ to 5, it's purely subjective. And there's really poor inter- and inter-observer reliability with this. And perhaps this is not the best test for us. And a lot of us now believe that functional tests are more important, like the heel-to-toe walking or the get-up-and-go test. So we started questioning whether we actually really need to do this manual muscle testing. So Jim Harrop, who's going to speak at the end, did this great pilot trial, and he basically sent this care package consisting of TheraBands and monofilaments to patients, and he did a televisit examining motor strength, sensory exam, and he did functional tests with this setup. He compared this to the traditional in-office exam. And essentially, his conclusions were that there were no significant differences between motor, sensory, or special tests between the televisit and the in-office exam. So now I think this is a great study by Jim, right? Because his setup was fantastic. The muscle strength testing was purely objective, and it didn't have the biases and the subjectivity of the MRC 0 to 5 scale that we all use in our offices. And also, it demonstrated for the first time that muscle testing can be done virtually, right? So fantastic study by Jim. The problems that I see with it are the logistics of getting this huge care package out to patients. I could see patients not getting their care packages on time. That could lead to canceled visits. And if they can't follow the complex instructions, that could lead to really long office visits. Additionally, with virtual care, we want to diminish costs, right? And the kits cost money, shipping costs money, and then you have to hire someone to manage this for thousands of patients in your office. So these were problems with this setup for me. So I envisioned a testing program where you can test someone with just a household object. And when we're testing people, I don't think it's really important to distinguish between 4 and 4+, right? These are supposed to be really good screening tools to help us basically capture all the pathology. And if we flag someone down, we could have them come to our office for further evaluation. We're not looking to close down the brick and mortar offices that we have. We're just looking to screen patients and have fewer touch points and to use our resources more efficiently. So to that end, myself, Mel, who's going to speak next from Walter Reed, Paul from Wisconsin, and the guys at Mayo basically collaborated to come up with this virtual physical exam of the spine. And it has several components. We look at general appearance, stance, gait. We do some functional testing. We have some physical exam things for the hip and for the shoulder to differentiate these from spine as a potential source of pathology. And in terms of strength testing for the lower extremities, we basically test strength against gravity. So for plantar flexion, for example, we have people do calf raises. And for the upper extremity, we have them use a household object, either a can of soup or soda. And we have them, for example, for biceps, do curls with the left and the right side, max of 10. And we want to try to see if they can do it against gravity and to detect any subtle differences. Now, this is a 4-page test and it takes about 10 minutes to administer the whole thing. If you're focusing on one specific part, like the upper extremity or the lower extremity, it takes roughly half the time. It's pretty easy to do. Along with this, we've sent out these virtual exam instructions, which are pretty clear. And they're a step-by-step way that the patients can do these tests. And the tests are all really easy for people to do. They're not complex. They're really easy to understand. So based on this physical exam, we have 3 research studies that are currently being done and hopefully should wrap up in the next few weeks. One's a QI study looking at the feasibility of patient satisfaction and surgeon satisfaction with telehealth. Another is a prospective study looking at the inter- and inter-observer reliability of our hands-free exam. And the third is a validation study of our hands-free exam, and hopefully it can serve as a proxy to the traditional in-office exam. So we have had some challenges with the setup, and the biggest challenge, I think, is the fact that the camera doesn't have a wide enough view for us to always see the patient's feet, for example, when they're doing heel raises. It's really helpful if there's another family member to direct the camera at the patient's feet so we can actually see what's going on. And even if you're doing half the exam, 5 minutes is still kind of time consuming. So these are the challenges that we have. So if we are going to critically look at the physical exam that we do, all the things that you see with red boxes are purely objective with no interpretation. So if we're thinking to the future, these purely objective things with clear instructions are things that patients can actually do themselves and fill out. So we can have access to this before a visit, much like we have access to lab values. And if we flag something that's abnormal, just like if you flag a lab value, you can delve more into it, into your actual exam with the patient. So in terms of the future directions, I think it'd be great if we can have a platform that can incorporate patient-reported outcomes. I think it'd be great if we can have an app where we can record people's exam scores. And also, right now, we have the patient and we have the provider. But if we can have individuals call in and be a part of this visit like a scribe or a resident, that'd be really useful for efficiency. And like Paul Anderson pointed out, if we could have family members that can call in, they can be involved in the care of their family members from distant locations. So I think it's really promising, and I think there's a great future in it. I'm going to let Mel pick up kind of where I left off, and he's going to talk about his experience with telehealth, and he's also going to talk about some of the regulatory issues pre-COVID and now. Thank you.
Thanks, Rock. So I think we've all been suffering through this early experience during COVID and being forced to do virtual health. But I think those of us that have done it before potentially have some opportunity to share our experiences with others. And I'm going to go through a little bit of the background from what we did in the military, go through some of the definitions that I find sometimes difficult, but certainly important, talk through our own personal experience and our experience within telehealth at Walter Reed, and then end with some of the regulations that are currently in place during COVID and will continue to be in place post-COVID and some of the differences between those. So as a bit of a background, most of us pre-COVID did virtual health or telehealth out of convenience. There are certainly some locations like the rural and underserved areas that were using it regularly. But the military really did lead this endeavor in a lot of areas. The military had to do it out of necessity due to the fact that we were in locations all over the world. We were in the Middle East or Africa, or certainly on a carrier in the middle of the Pacific Ocean. And so our patients expected some level of expert care to be delivered in these remote locations. And on the right side of the screen here, you can see a Global Med pack. The Global Med company is a partner of the military, and this is a pack that our special forces can carry. And on the left side of the screen there, you can see a picture with President Trump and Secretary Shulkin with the Global Med cart. Certainly as the president travels around the country, virtual health becomes very important. On the bottom of the screen here, you see a couple more pictures. This is actually the same Global Med cart. This is in the middle of the White House Medical Unit. And you can see an image on the right there is actually the inside of the ear of one of our PAs. And I show these pictures to make the point that virtual health is really effective for ENT or ophthalmology or some of other specialties like cardiology. But in the realm of spine surgery, it hasn't been as effective. The military, we essentially have been forced through the National Defense Authorization Act of 2017 to push telehealth into all of our specialty care environments. And at Walter Reed, we've had to follow suit with this. And I'm going to spend a little bit of time going through a few definitions. I know we're trying to move through this relatively quickly. And I think if you're seeing the terms telemedicine, telehealth, virtual health, a lot of those can be used interchangeably. And I'm not going to focus on those. A couple of definitions that everybody needs to understand are the differences between synchronous and asynchronous telehealth. So synchronous telehealth is the real-time live interaction between a patient and a physician. The asynchronous, a good example would be the imaging review. The patient gets an MRI that's uploaded into your system, and then you review it the following day and then provide some feedback on that imaging. That's the store and forward telehealth. Most of the regulations do not allow for much asynchronous telehealth. A couple other definitions that are important to think about, and these were relevant when I first did the training for telehealth, is the differences between the originating site and the distant site. So the originating site is where the patient is located at, and the distant site is where the physician is located at. This is important when you start looking at some of the Medicare rules, and this is all pre-COVID. There were only a set and a limited set of locations that would be considered as an originating site. And of note, the home, except for dialysis patients, was not a reimbursable location as an originating site. The distant site is where your credentialing has to be obtained through, and frequently some of these other originating sites, you need a credentialing by proxy through the originating site. Prior to the waiver, we really weren't doing much telehealth, except in certain demographics, like in the rural areas. But after 2019, CMS did expand the telehealth program, and I think that this is just evidence that the telehealth and virtual care is being expanded. Two new terms that they added were virtual check-ins and e-visits. E-visits are essentially the online portals that everybody has, and virtual check-ins were very short, patient-initiated 5 to 10-minute conversations. So my own personal experience in the military, I think we all have learned quite a bit from going through our own experiences, and I'm going to share a little bit of what we do at Walter Reed. When we were forced into this virtual health endeavor through Congress, we set up a process that can be expanded to really every practice within the military. For us, we go through about a 2 to 3 hour training that follows with a training certificate that then you provide to your credentialing official. Once you have the credentialing uploaded and that certificate in your file, you meet with somebody face to face who shows you how to set up your camera, and some of that's useful because there's things we don't always think about, for instance, camera position or the lighting behind us. And once we do that, we are allowed to see patients, but we can only see patients in the states that we're licensed in if they're in their home. So we don't have to comply with the same Medicare laws, and so we were seeing patients in their home, but we could only see them in the states that we were licensed in. So if I'm licensed in Maryland and Virginia, if I have a patient in Virginia, I can see the patient in their home, or if they go to a Virginia medical facility in the military, I can see them in that facility as well. But if I see a patient that's from Kentucky, I can't see them in their home, and I can see them if they go to our military treatment facility. And those rules are a little bit hard for certainly to learn right out of the gate. All of this has been waived during our current crisis, but as the department head, I'm still forcing our surgeons to go through the training and the credentialing process, because I do believe that this is going to be something that we have to do post-COVID. My personal workflow, about 24 to 48 hours prior to a clinic, we identify the patients that are appropriate for virtual health. Certainly right now, we're pushing as many as possible into this. The nurse then has to send the instructions. The instructions are 2 PDF files that go out. Pre-COVID, we would have to do a written consent. The military requires a written consent, as do certain states. And then we instruct the patients to connect in at the time of their appointment. And then on the day of the clinic, I open the room, and I'm the one that allows the patient to enter, similar to Rock's setup. We use Adobe Connect. We're not on the Epic platform. And this is kind of what my setup looks like. These are just screenshots of my my own personal setup. So on the left, top left image, that's my left screen. I use 2 monitors. And then on the right, upper right is my right screen. My right screen contains Adobe Connect, and my left screen has the imaging study. The patient then connects, and these bottom 2 images is just my own iPhone connecting to the platform. The patient clicks on the link, then this pop-up comes up that basically gives them, forces them to say that they're giving consent to the telehealth services. Once they click on that button, they then go to that bottom right image, which is the waiting area. So the patient just sits there and waits until I'm ready for them to come in. And on the bottom right-hand screen on the upper right image and the bottom right of my screen, I get a little notification that the patient is ready to come into the room. If I'm doing something like email or some other activity, I will just sit there and I can invite them in right away. If I'm engaged already with another patient, I will disconnect with the other patient eventually and then invite the patient into the room. This is what my setup looks like. The top 2 screens, once the patient's in the room, I pull the electronic medical record up on my right screen. That's not something the patient can see. My left screen is still shared with the patient. And then I split my right screen between the camera and the electronic medical record. The patient on the bottom 2 images is, again, the patient's view. If they're on their iPhone, you see the bottom left image. They can toggle between these 2 images. The bottom left is making my left screen their full screen, and then the bottom right image is how they can toggle to see my camera and go between those 2. When I'm going through and talking to them, I prefer them to be on that bottom right image, and then once I go through their imaging with them, I have them toggle back to the left image there so that they can see exactly what I see when I'm going through their imaging. The things that are easy for me to do are really getting a good history, and frankly, I'm better at getting a review of their past medical, surgical history, and looking at those reports, because I put my camera right above the electronic medical record on my screen so that when I'm going through the record, they see me as kind of engaged and looking at them. So I have the ability to kind of continue to be engaged with the patient, and that's different than when you do an in-person eval. You can't really go and look at their chart without them kind of getting the perception that you're disengaged or less interested in what they're telling you. It's also really easy on Adobe Connect for us to do an imaging review, so that, like I showed you on my screen, I can see, the patient can see exactly what I'm seeing, and I can scroll through their images, talk to them in detail about what I see is wrong, and I find that to be even better than in person. It's also easy to do outcomes collection because we're engaging with the patients in advance. You can talk to the patients email the patients in advance, and because we have to do that to give them the instructions, we can engage at that point in time and collecting some patient-reported outcomes. The things that are difficult, as Rock mentioned, the physical exams are difficult. Ending the appointment I find to be a little bit difficult because the visual cue of walking to the door, or putting a hand on the door, or somebody coming and getting you out of the room, that's a lot different in the virtual environment. It's also difficult to incorporate your physician extenders. You end up doing a lot more of the work, and same thing with the residents. And that also makes teaching and G&E harder for residency programs, as we have all three. That I find that to be difficult. I bring a resident in, they can watch me do it once or twice, but it is not all that interesting to sit there and watch from their perspective. So the last section I'm going to go through here, and trying to be aware of time, is some of the regulations, and I'll try to cruise through these a little bit so that Jim has a little bit more time. The big thing here is right now we are underneath the 1135 waiver. This waiver, it has the intent of removing barriers for physicians and allowing us to conduct visits from home. It really has turned off a lot of the regulations associated with doing telehealth. This is taken straight out of the 1135 waiver. You can see those bottom two rows, the virtual check-in and e-visits. That's the same as it was pre-COVID. The thing that is different is the top row, which is the Medicare telehealth visits. And this is what we are focusing on doing right now. This is the provider communication with a patient, and essentially trying to code and document the same visit that we would try to do in person, and the same E&M codes that Jim's going to go over a little bit more detail. I'm also going to put a notice out there for those who don't have telehealth platforms like some of us do. Just yesterday, the funding opened through the FCC for the $200 million that was part of the Coronavirus Aid, Relief, and Economic Security Act. So there's $200 million available from the federal government for expansion of telehealth. And I think that opens up a very unique opportunity for folks. Post-COVID and pre-COVID, we were very well aware of all of these things listed on this slide. And post-COVID, we're going to go back to being aware of these. Licensing is a state-specific thing in this country. There's certainly some folks that have tried to align a compact across states or reciprocity across states, but state licensing still remains a difficult thing in doing telehealth. The regulations are also, unfortunately, state-specific. Certain states limit your ability to do an initial in-person visit. The consent regulations are different from state to state, and there are some differences in the ability to do asynchronous visits from state to state. HIPAA compliance, like Rock has already alluded to, is a difficult thing on certain platforms. Certainly the Epic platform is HIPAA compliant, as well as the Adobe Connect platform. But you have to know some of the details about your platform in order to assess whether or not things are getting encrypted and decoded when they go through transmission. Malpractice coverage is also important to consider. You just have to contact your malpractice carrier to determine whether or not you are authorized to do telehealth as part of your malpractice insurance. In the future, and I like to show this picture on the right here. This was a survey done in 2016 by the advisory board of 5,000 patients, and they basically picked a variety of different things that patients engage with their providers on. And you can see two of the five that were above 70% of respondents felt that in the pre-op and post-operative care realm, they should be able to do those virtually. So that is certainly in our wheelhouse as spine surgeons. In the future, I think the reimbursement is going to change. The COVID waiver is certainly exposing the opportunity to conduct more virtual health. As Rock alluded to, there are patients that you have to do in person, but there are certainly patients that if you get a good patient-reported outcome, a good history and MRI, that the physical exam may not be of as high a value as we think it is, certainly as in the past that we've focused on. In the future, patients are also going to expect this service. So we have to define who the clinically appropriate patients are and know the regulations, because when we're having these conversations with patients in the future, they're going to expect it. So in summary, during the current COVID crisis, we just have to do it. We just have to do telehealth, and it's a unique opportunity. There are certainly some business endeavors here that you could expand your population and your scope of your clinic to other states that you wouldn't normally be engaged with right now. But post-COVID, patients are going to expect it, and we are going to be expected to understand the state rules. And when they remove that waiver, we need to know what the state rules and regulations are so that we can continue to deliver this service. Also knowing that there are going to be changes post-COVID. And at this point, I'm going to turn it over to Dr. Harrop, and he's going to talk to us a little bit about their very extensive experience there at Jefferson and go through some of the documentation and coding rules.
Thanks, Mel. Am I switching over here? Thank you guys very much. Mel and Rocky did a great job. You took a lot of pressure off me, and many of your points I'm just going to re-hit one more time. So we might remember this is the now known as the last spine meeting, but in March at the spine section, I was asked to debate on telemedicine and why not to use telemedicine. And I'm just going to go through and show you back in March, my practice, and I was the largest provider of telemedicine and the neurosciences at Jefferson at that time. Out of 43 patients I saw in a day, 2 of them were telemedicine patients. And interestingly, at that time, I was seeing some established patients, which really were film checks, and post-op patients. And those were really the only 2 people I was seeing. Now we skip ahead, not even a full month of time, and I'm now seeing patients 3 days a week. And what we're doing is we're now doing these patients virtually, seeing about 15 patients. And I asked my secretary and the office managers today to calculate how Jefferson's doing. And we're actually up to about 60 to 70% of our volume based on last month's numbers on new patients. So overall, doing pretty well. Sorry about that. All right, so Jefferson has a huge telemedicine experience. This started over 10 years ago. My chairman, Robert Rosenwasser, and there are some differences between telemedicine and telehealth, which we won't get into. But really, the neurosurgeons and the stroke neurosurgeons have been doing this for numerous years. Pennsylvania and Philadelphia is way away from the rest of the state. And I see a lot of people like Rock does, who's 4 to 5 hours away. And some of these patients don't want to come back to see their normal post-op x-rays. And so what we did is we took off those people, and this is their telehealth setup. They have 35 different hospitals where they have robots inside their hospital system. So we had this huge network. And then they expanded, and they use robots for ICU rounds and in the ICU to check on patients. And out of that, they evolved into the telemedicine platform where we started seeing patients. Our institution had a big push forward to this, and I think I'm now on my 4th platform of different telemedicine platforms where we've gone from, and I'll talk about reimbursements, but we've gone from the G codes where essentially we weren't getting paid, and then we went to a system where we were asking the patients to pay $30 to $40. And now we've gotten into the point where your Medicare populations are equivalent pay if you go into time billing. And we'll talk about that in a second. I do want you to realize that there are some challenges with telemedicine. Reimbursements not being profitable. I think that's changed. This article is back in 2006 or early 2000s. The EMRs are so much better than what we started with. The legal consequences are going away. The technical difficulties, and you're going to see the plethora of different platforms. And then not being able to do exams, I think we're getting over the top of that and we're understanding it. Again, Rock, I think, pointed this out, but telemedicine really started out as visually oriented groups, dermatology, wound care, ophthalmology. But if you go way back to the beginning, spinal cord injury was there. So there are great benefits with telemedicine, and it almost makes you want to get a license in every state, which fortunately we actually have right now. and we'll touch base about that a little bit. But the access is unbelievable. You can go across the U.S. I have patients. I saw consults in Florida today, New York, Pennsylvania, New Jersey. So you get access to everyone. The second amazing thing that's happened in this crisis is not only do you get access around the state, but how you can communicate with them is opened up. Your cell phone has now become a virtual EMR. And so with that, you can use that to use any of your patients. And the government, I actually got this off the HSS websites, but these are all the different platforms that you can use. And I'm not going to go into the verbiage of it, but basically they're saying that it's more important for you to take care of your patients than it is HIPAA right now. And the government's going to overlook HIPAA violations under the assumption that you're doing good faith in trying to take care of your patients. And I think that's really the message of this whole waiver that Mel was talking about. Again, there are some drawbacks and there are some questions. And I actually thought, even a month ago, I thought these were bigger barriers than they are. The breakdown in the patient relationships. I've never been more on time in my life. Patients just see me. If they have a 15-minute visit, you turn on the web camera, they think they're going to be there 15 minutes and they're ready to get off. And I'll go through my workflow a little bit. But again, the neurologic exam, I don't think it's as big of a barrier. Rock talked about what the project we did. However, we didn't do that for the average telemedicine patient. We did that more for clinical trials with spinal cord injured populations. How do you test a quad patient who's four hours out, who's a huge barrier to get into the patients? And I think his approach is going to be great and pushing us forward and how we understand the neurologic exam. The problem from a reimbursement, you're probably not going to get it to the point where the government really thinks it's an acceptable, 3-system check for an exam. And again, we talked about that, so we'll skip it. So I really want to step back and talk about my part of the time and really just concentrate on what do I do? Say I haven't had it, don't have a platform, how do I get going and how do I do it? And I think what I learned over the last 10 to 15 years is you need a team. You need someone to be over the charge of it. You need an administrator. And if you can get a nurse to help you at the same time, that's great. The malpractice, I'll touch base on that because it's interesting. It's actually not that big of a barrier, but you should check what your malpractice cover payments. You should also have an understanding of payment and how you go. And I'm going to give you a bare bones discussion on that. And you need to know some of the policies of telemedicine. Fortunately for right now, those are easy to overcome. The problem, I live between Pennsylvania and New Jersey, and the laws in those two states are completely different about which patients you can see, how you can see them, can you prescribe any medications. And so I think, as Mel was saying, it's a great time to get involved, understand how to do it, but there's probably going to be some changes back. So once you have that set up, the next question is you need to get a vendor. Most of us, particularly if you're in an academic setting, you have an EHR. And if you have an EHR, most EHRs have systems, and they usually have multiple different systems where they can be turned on. You can now, if you don't have that option, you can use anything you want. A lot of people have turned to Zoom. Another thing, and I'll show you, Doximity's got another app. I've been using FaceTime, believe it or not, which is very easy to use with patients. But I think it's great to have multiple different choices. You should always look at prices and understand how prices are covered. But the second thing is there's something called the American Telemedicine Association, and they're a nonprofit organization dedicated to helping with telemedicine. It's a great service you can use. I have all these links set aside on the Lumbar Spine webpage, so we'll be able to hook you up with those if you're ever interested in any of this. So now you go, okay, I know what I'm going to do. I got my team. I got my EHR. Now, what am I going to do for work call? And this is something where I think it takes some time to do this. If you're going to start out, I'd probably start out about 30 minutes a patient because it's the technical glitches that I find the biggest barriers with patients. But realistically, you probably need about 15 minutes for a patient, and that probably includes new patients and established patients once you get doing this pretty well. I have pretty much all Medicare patients or Medicaid patients, and so for me, that's kind of easy. But if you have a predominant payer, you probably should go look at them and say, what do I need? And then again, I think you need to go through and say, where's my system? How do I want to arrange it? But you need to be flexible. because I change my system every day. I go through different patients and I find something new, and I talk to my partners every day. One of the things you want to do, and Mel sort of mentioned this, is you want to have a consent. It doesn't have to be written at this point. A verbal consent is totally fine during this crisis period. There are multiple consents, and I have a link where you guys can find one. But then you need to get patient flow, and you need to figure out how you're doing. And if you heard Rock and Mel both somewhat say this, is they have a pathway they have. So it's good to have a flow diagram, a way you want your day to go. One of the things that I'll show you how I do it, but we have the MA call the patient the day before, because I found that the biggest barrier is technology in your older patients. You know, everything's great, but they don't know how to turn an iPhone on. They don't understand where the volume is. So that'll work out those glitches. By the time you see them, their anxiety is so much better. And if they can't do it, then you default to a phone call, and then I'll show you how you go through that, and you can still get reimbursed with a phone call with some of the changes. It's also good to prepare the patient, because again, a lot of these people are anxious, and these were all taken from the AMA website, where you can send it to a patient and say, this is what you need to do. Here's a checklist. Can you do this ahead of time? Mel talked about malpractice. Very interestingly, the malpractice for telemedicine, as of now, is almost non-existent. This is a paper back a couple years back, but I've gone through a couple of times, and I actually even talked to our health department today, and they said that in most places, if you go to a telehealth platform, they actually reduce your insurance coverage because claims are so much lower for telemedicines. Being from Philadelphia, I have full confidence the lawyers are going to pick up on this, and that won't last long, but that's where it is now. The second thing I wanted to know is good news is, as we talk about reimbursement, in many states, I think it's up to 30 states right now, and again, you can see this is from the American Telemedicine thing, have had parity laws. Parity laws essentially mean that if Medicare covers it, the states have all put laws in that insurance companies must reimburse at the same rate as Medicaid. What's happening is a lot of insurance companies will say, yeah, we'll pay for telemedicine, but we're not paying you for a full patient visit. We're going to only pay you 10% of your charges. And so those laws, at least in these 30 states, have changed. All right. Now I just want to quickly go through exactly how I do it. So I set up my office with three different things, and I think they're kind of important. One is, this is Rock's notepad, because he doesn't have any electricity, I guess, in his house. But a laptop computer with your EHR on it. That's great, because what it does is you can type in your note, or if you have Epic, you can put dot phrases in, and you can go through your system and just scribe it, or just type it right in. I've done this with scribes. It's never worked out well, because it's always been, they're trying to do your note as you're trying to do it, and it's a much faster pace, and that's why it's very important to be organized. The second thing I have is usually your telemedicine platform. We actually have this is an iPad, which has a separate thing that's hooked up through Epic, but this is where you can use your Skype or your, it's interesting. If you read government policies, some places they say you can't use Facebook and some say you can, but we'll just say your Zoom or your Skype or even your Apple Talk. The third thing, and this is what, one of my partners taught me this, which I thought was fantastic. We now have we all got Zoom accounts. And what I do is I put my nurse and my PA on my Zoom in the background. And what they do is they hear everything I say to the patient while they're working on their desk. And I have them off on mute. And then we'll communicate back and forth. And at the end of the day, they follow up with every patient and they get them their scripts or everything. But they've already heard the discussion, what I have. And so it saves a lot of time and a lot of confusion for them on the back end. This is my Epic Note. If you're an Epic Note person, it's called a dot phrase, which means it instantly comes up. And there's two things I want to point out. Is one, in your note, you should say that you had a telemedicine device. And that means that you need to have direct voice and imaging present. Otherwise, it's a phone call. The second thing is you need to say that you had consent obtained. We actually do this before the patient sets up their telemedicine appointment, sort of like Rock does. We have it all set up ahead of time. And the third part is you need to switch to time billing. And the reason why is we'll get into that, but you really are not going to hit the necessary requirements to bill on physical exam. So you have to have something to say XX minutes, and then I'll go into that in a second. And 50% of the time was spent in counseling or coordination of care, or greater than 50%. Those are the key words that you definitely need to use in order to get credit. This is the consent form I told you. If you want to get consent forms, this is a nice place that has sample consent forms for it. Another app which I thought was useful, I found out this week, was a Doximity app. It actually is another exact same thing. It's nice because it gives them your patients, they get your office number, and you basically call the patient up, hit video call. It then says, notify me for a link, and then it sends the patient a link, and then the patient gets this thing where they say they consent to do it, and then they hit it, and all of a sudden you have a direct video talk. This is actually HIPAA compliant also, so it is another nice thing. This is something that Mel was talking about, and I think most of us think about telemedicine as a synchronous event, and I'm going to go and talk to you real quickly because I'm running out of time on the non-synchronous type of events, including phone calls. So if you look at it, most of us know the new patient and established codes, and this is, to me, what you're going to base all your billing on. And then second of all, if your telemedicine doesn't work, usually you're going to fall into your phone calls or your video category. And these are the codes for those. And the phone calls are going to fall into the 99421 to 423. These are newer codes, so most of you probably aren't that aware of them. Just the place of service should probably be O2 for telehealth. Although if you're into your billing and everything, you probably should also realize that there's some thought about from CMS that you should bill to where you were going to be and use a 95 modifier for telehealth. Okay. All right. Lastly, I just want to go through two quick things. One is this is your new patient codes, and you're all used to the exam codes, or at least I was until a couple of weeks ago. You can't use these, so now we're going to go over to time bill codes. And if you're into billing, which I'm not really into that billing, I sort of just do what I do, because most of us as surgeons, this is only a small percentage of what our revenue is from, is probably the middle codes, 03 codes are probably your most efficient codes, because essentially as you go down, you get more credit per time, thinking that there's going to be a transition time in your care. This is your RVUs, and if you know your RVUs, you know an RVUs are worth, I think it's $38 essentially right now in the Northeast. You're not going to be making tons of money by doing your telemedicine bills as much as you probably wouldn't be doing them using your regular EMR bills. However, say you're getting on the phone and your patient, you can't get that EMR to work for whatever reason. One of the things that we have is Jefferson's went from having 50 telemedicine appointments a day to, and that was the week before this COVID crisis happened, we now have 3,000 telemed visits a day. And the problem is you notice that I started talking a lot of out-of-network systems, is the bandwidth at your hospitals, if you have a big hospital system, isn't that large because they didn't anticipate 3,000 calls. And so we've been going outside the system using FaceTime or the Doximity apps or Zoom. But say you have to use your system and it crashes and you can't have the talk with the patient and you only have essentially a telephone call, the codes to use are these 994 codes. And again, these are time billed. You have to tell the patients that A, the patient initiates the call, 2, it has to be an established patient, and 3, it can't lead to a direct appointment. And it's important in your note, here's the big take-home message. You have to say, I was on the phone or I was directly talking to the patient for that amount of time. 2 last codes that I just want to mention, they're G codes. And that is, one is that there's the G20112. That's essentially if you're having a virtual check-in or a call on a patient where you're just calling and saying how you're doing, 5-minute talk. The second code, which is an interesting code, is 2010, which again, these are not great RVU revenues, but that's if a patient sends you some films and you want to, you review the films and you get back with the patient you can bill for that time too under that code. If you have Epic, I don't know if you do, one of the things that I did is I changed my level of service box down at the bottom. If you hit the wrench, you can rechange your templates. And if you search under telephone, it'll pull up the different areas, and you can just modify the code buttons to have, if you can see on mine, I made them, they're time billed, and on the bottom right, they have the exact times for the codes, and you can just hit it. These are the helpful sites that we were talking about, and Katie put these all on our website, which are more than available. And with that, I say thank you from Philadelphia. And back to you, Raj.
Thank you, Jim. That was excellent from all three presenters. Unfortunately, we're coming close to the end of our time. There's a few questions. Mostly, the comments have been outstanding and very complimentary. One of the comments said, "This is the best webinar I've seen during the COVID crisis." There are a number of questions that ask whether the slides from the panelists will be available. The slides will not be available, but the Lumbar Spine Research Society will put a video of this webinar up on the LSRS website. So please check lsrs.org, and we should have the webinar videotape on that website at some point in the near future. There is a question I'll ask you, Jim, and if you could give us quick responses. I'll try and go through as many of these questions as I can. For new patients, how do you triage which patients can come in and be seen via telehealth visit, and which patients should come in for an in-person office visit?
And so what we've done is we've gone completely virtual. And so we do not see patients in the office anymore. Matter of fact, we've sent all our secretaries home and our administrators are home. So I've seen only new patients by telemedicine. I've yet to see a true crisis where I needed to see the patient in person, but that's sort of how we've done it. I don't know about the rest of the guys.
Rock?
We're doing something similar where we're seeing our patients pretty much all virtually. If there's someone that has a problem like progressive weakness, and we offer a clinic every day of the week. It's a general clinic, and one of our faculty members staffs it and essentially sees what comes through that day. So there's an emergency-only clinic that we have.
How about pre-COVID? How would you triage who should come in for an in-person versus a telehealth visit?
Yeah, so I was trending towards. Oh, sorry. Go ahead, Jim.
Oh, no. Go ahead, Rock.
I was trending to essentially try to see as many patients as I could for pre-COVID video. And definitely my follow-ups, most of my post-ops, and most of the fracture cures as well. And we're transitioning to seeing new patients like that as well. So for us, it's just a question of getting our workflow optimized, which we were really getting close to before COVID hit.
So I also comment on that, Raj. We are still doing our in-person clinic. So in advance right now, we're having our clinic screened by the PA to determine if there are consults. And sometimes it's not easy to define, but the thing that was mentioned is the progressive weakness. Anybody with progressive weakness, we want to have them still come in person. But moving forward, I think that that's part of the point that I made in my talk, is that I think we have to define this population. Our patients are going to expect it, and we need to now have a better understanding of who we can't see over virtual health after this crisis.
So I'm going to actually go back and say I completely switched my stance. So in March, I saw no new patients. I probably see 3 to 5 a day now. And I actually think it's been great because you talk to them, you understand exactly what's going on. A lot of these people are fairly complicated. And so you can get through a lot of this stuff. And then when they come in, you get to figure out exactly what to examine. So I was very hesitant for it, but now I'm totally willing to see anyone.
Paul, what's your sense? Do you see any advantages to telehealth over an in-person office visit?
Yeah, I see a lot of advantages. I think that for the patient's convenience, for sure, it allows you much greater outreach for patients. I think you can triage them a lot better if you see and talk to them if it's questionable about whether you need to see them or not. That's a big advantage. And the other one is, Rock mentioned this, is maybe being able to get their families combined with the patient all on the same phone network so that you can better involve the family. I don't know if the platforms allow that as yet, but that will certainly be a future opportunity for us to get better family involvement with that. I think another area that nobody mentioned, but maybe follow-up patients who go to SNFs who sometimes languish there for 6 weeks or something. We might be able to do follow-ups there. That might be better for hip fracture patients or perhaps some of the spine fracture patients. I do have one question for the people who are using their iPhones as part of this. Are you de-identifying yourself on the iPhone, or do you use some other proxy application to do that? Or doesn't it matter to you?
We go through when we do the video visits, we go through our Epic platform through Haiku, and I think that does that for us. When we make phone calls, I started. Yeah, go ahead, Jim.
Oh no, you're totally right, Rock. Haiku does that. Doximity does that. If you directly call them, you have to go into your. It depends if you have two different attitudes. One is I don't care, and they're going to call you back, or you can go into your settings and you can block your identification. It's a very easy thing. You just go to, you can even search block my calls, and there's a slide thing that blocks your identification of people. But you tend to have to, if you want to re-identify yourself, you have to hit *82 on your calls.
Well, let me ask you a quick question. Do you think that there might be a subset of patients who are actually more satisfied with a telehealth visit than an in-person visit?
Yeah, I definitely think so. The 2-week post-op patient that's miserable and spends a half of their day coming to see you, certainly in the DC area, they can sit in traffic for a couple of hours, and it takes quite an adventure to get in and out of our clinics. That patient is much happier seeing you virtually, and I frequently can go through their post-operative imaging with them, and I unlike Rock mentioned, he's got pretty good camera clarity. I found that it's a little bit easier to have a patient send me a picture of their wound at 2 weeks post-op, just for a little bit better clarity on the wound. But you can look at the wound. I've had patients just take their phone and show me their wound, and the immediate post-op patients really appreciate that. They don't like sitting in the car and driving to see you.
Rock, are there any concerns that patients may be recording some of these telehealth visits?
Honestly, I haven't even thought about that. And to me, it's not a concern. I mean, I have patients in our clinic take out a tape recorder or record on their iPhone, and I'm totally fine by that. It's a brief amount of time, and it's a lot for them to process, especially because they don't speak the medical language that we speak. So I think it's really reasonable if they do. Yeah, it's a good question.
Jim, can you link in a third party, like a work comp case manager, for example, into your telehealth visit?
We don't have that technology. Paul said it. It's interesting. When you have these meetings with people, it's very interesting because they set up like you're on a phone call, and I've never had, and Rock, you might want to comment on this, you have a lot of experience too, you never have two people sit down on the camera. You'll have the wife walking around in the background, but they never have two people sitting there looking at her. So it's always done, and then you'll hear the wife chime in that you're an idiot, but you never have two people look at you.
Yeah, no, that's true. So on the Epic platform, the capability does exist. We haven't been doing it yet, but it does exist for you to add in a third and a fourth person into it. And I think a really useful thing would be if you're taking care of athletes, we take care of quite a few athletes, you see a patient, an athlete, and then you have to call the head athletic trainer, then you have to call the coach, and then you have to call the agent. And it's a waste of your time, and somewhere along the chain, the story gets mixed up too. So I think there are plenty of benefits to incorporating other people. I actually just sent an email out last week about getting this done, and apparently Epic telemedicine platform is capable of this. We haven't done it yet, though.
Can I ask the guys just
another quick question, Mark? What is the workflow for gathering all of the necessary medical history, medications, social history, etc., that will then be automatically subsumed into the medical record for your telehealth encounter? What is the actual mechanism?
So by and large, for the most part, most of our patients already have this stuff already in there because they're follow-up patients. And we just started seeing new patients fairly recently in this. A lot of our new patients are Michigan patients anyway, so they have MRNs and account numbers already established with them. So I really haven't taken any other measures to incorporate any of these things.
Let me just end up with this final question from one of our past residents, so I have to ask it. He says, great webinar. This is Dr. Uchiwala from NYU. He says, my question concerns the physical exam assessment for telehealth visit. What's the learning curve for patients when you conduct the physical exam at their home? Mel, do you want to take that?
Yeah, I've done quite a few of these the past couple of weeks, and the patient, with the instructions that Rock alluded to, they generally understand the motions that we're going to take them through. The first couple with the soup can or soda can, it's a little awkward to kind of coach them through it, but they move on pretty quickly, and I have not had any patients complain about the visit at all. They really do appreciate doing more and more on a physical exam. Some of that, in the current crisis, patient satisfaction is probably going to be higher, and they're more willing to go through this process and do a physical exam over the virtual visit. And post-COVID, they may not be as willing as they are right now.
And Raj, I'll get a quick comment on that.
Sure.
It depends on the limitation is this: how the patient has their camera set up. So if they have it on a desk camera and they have no back wall, it's torture. If they have a phone, it's much easier, or have someone who can help them do it, because it depends on to me, it's trying to get someone to walk down a hallway, you can't see them. So.
Well, thank you, gentlemen. Thank you to the audience. It sounds like telemedicine and telehealth is here to stay, and this may be an opportunity, the COVID crisis, for all of us to perfect it as we move forward. I'd like to particularly thank Katie Schiefelbein, the Executive Director of the Lumbar Spine Research Society, who helped put this webinar together. I'd like to thank our outstanding panelists, Rock Patel from the University of Michigan, Mel Helgeson, Chair of Orthopedics at Walter Reed, and Jim Harrop, Professor of Neurosurgery at Thomas Jefferson University. And on behalf of my co-moderator, Paul Anderson, and myself, I'd like to wish everyone a good evening. Stay safe, be healthy, and we will come out of this at some point stronger, busier, and with a new set of skill sets that we will put to good use down the road. Good night.
Thank you, everyone.
Thank you, guys.
Thanks, everyone.
Take care.
Great job.
Thank you.